I use the loop tip primarily for pure biliary therapy cases where the goal is biliary access, sphincterotomy, and stone extraction or stent placement or whatever. We also use it in chronic pancreatitis cases, sometimes in the pancreatic duct. Because it's so large and stiff, I tend not to use it in patients who I consider high risk for post-ERCP pancreatitis, or where we're going to plan pancreatic therapy in small duct pancreas cases, such as pancreas divisum or sphincter of Oddi dysfunction. But for most biliary applications, especially in virgin papilla anatomy, where our goal is just to get into the bile duct, it's quite useful in combination with the papillotome. And if we do get into the pancreas, it actually is possible, and we have quite often put the wire into the pancreas and place pancreatic stents over it. So if you do inadvertently get in the pancreas and feel that you need to ultimately place a pancreatic stent to reduce risk in the process of getting biliary access, it will work for that too. It seems to be a more stable guide wire, and the stiffness allows you to do vigorous stone extractions with balloons. You can do stenting quite effectively over it through difficult high-grade strictures. The loop tip is different in that it has the paddle-shaped tip, which theoretically and in our experience will pretty much stay in a duct or go nowhere, but it's very unlikely to cause a false passage or exit a side branch in the pancreatic duct. It's also quite stiff, much stiffer than a usual wire, especially a hydrophilic wire, which is what's generally used for guide wire cannulation. And because it's so stiff, you can actually use it like a cannula and direct it upwards or downwards. So in some ways, it's when you use the pure wire technique without impacting the cannula in the papilla, it's more like using a very small, stiff cannula. And then once it's in the duct, it will usually pass freely into the duct, and then like any wire technique, you can see generally, although not always, if it's heading up the pancreatic duct or the bile duct. Then if it's heading up the pancreas, you withdraw it, redirect it. Step one is wire from a distance. If that doesn't get us anywhere, step two is to seat the papillotome, change the angle, and try passing the wire. And if that doesn't work, step three is to inject a tiny little bit of contrast, because a little bit of contrast won't hurt, and it sometimes will tell you, which direction the duct of interest is, or it'll tell you which duct you're in, and can help you negotiate further into the papilla with the papillotome, at which point then you can pass the wire. And if you get stuck in the pancreatic duct, it's actually quite useful then as step four to place a wire in the pancreatic duct, leave it there, come out and go back beside it with a second wire, can be a loop tip wire, and then find the bile duct by skipping over the septum. And the function of that pancreatic wire is to straighten out the common channel, lift the papilla towards the endoscope and stabilize it so it's not moving. And also because sometimes with a downward pointing papilla, it will lift and straighten it and pull it towards you to make the bile duct easier to find. And we found that double wire technique of pancreas followed by biliary wire is quite useful with the loop tip.